Assalamu alaikum. Okay, so today, ليش احنا في دراسي؟
لا بس قبل
أحسن. Right. Today we'll continue with the small intestine. Okay, last time we spoke about the duodenum. We said the first part of the small intestine is the duodenum, and we said it's only 10 inches long. It's only 25 centimeters, and it is C-shaped, hugging the pancreas. Okay, and we said that the first part, the duodenum, is the retroperitoneal structure. It is covered. If you open the abdomen, you're not going to see the duodenum, because it is covered by peritoneum completely, except the first inch. I'm talking about the duodenum, except the first inch of the first part. First part is 2 inches. 1 inch is covered by peritoneum, where we have the hepatoduodenal ligament, and the rest is retroperitoneum. So, this is the first part of the duodenum. Only the first inch is covered by peritoneum, where we have the retro with the hepatoduodenal ligament. If we open the hepatoduodenal ligament, what we're going to see there? The portal triad, which is the hepatic artery, bile duct, and the portal vein. Now, in terms of relationship to the first part of the duodenum, for you to be able to see this, you have to lift the liver. If I let the liver go down, this part, which is the quadrate of the liver and the neck of the gallbladder, will be in touch with the first part of the duodenum. So anterior to the first part of the duodenum is the quadrate lobe and the neck of the gallbladder. Now, posterior to the first part of the duodenum, what do we have? These structures will continue down. The common bile duct, as we discussed last time, and also this artery, which is the gastroduodenal artery. And we said it is important because if an ulcer perforates posteriorly, it might erode the artery and will result in bleeding. Okay, and so we'll have the portal vein, we'll have the gastroduodenal artery, we have the common bile duct, and also we have the inferior vena cava. Now, superior to the first part of the duodenum is this opening into the lesser sac. What do we call this? If you had a lecture on peritoneum, will not hear? Yes. What do we call this? Epiploic foramen, right? This is the epiploic foramen. You can see it in the lab. You can insert your fingers in there. It goes to the space behind the lesser omentum and the stomach. What do we call that space behind these two? The lesser sac. Okay? Now, inferior to the first part of the duodenum, of course, is the pancreas. Okay? Now, how do we know that we got into the duodenum? The first part of the duodenum is called the cap, and the mucosa of the cap is smooth. So if the patient swallows a dye, we call the barium meal. It's a diagnostic tool. We ask the patient to drink something white, barium, and we start taking pictures and see if barium is gonna, will show us the contour, will show us if there are ulcers or no. So the first part of the duodenum or the duodenal cap is going to be smooth, and then we're going to have these mucosal folds. We call them plica circularis, mucosal folds. So the barium will be broken. It will not have a smooth outline. Okay? Now, the second part of the duodenum is the descending part here, and as you can see, posteriorly it is related to the kidney and the renal blood vessels. While anteriorly, if I let the liver go down, it will be in touch with the gallbladder and the right lobe of the liver, and of course the transverse mesocolon, which is the mesentery that attaches the transverse colon to the posterior abdominal wall. Now, what is special about the second part of the duodenum? This is the second part, anterior to the kidney, and anterior to it we have the liver and the transverse mesocolon. What is special about the second part of the duodenum? Yes, we have the ampulla of Vater, if you still remember, which is basically a duct that combines the pancreatic duct with the common bile duct, and it opens in the second part of the duodenum, pushing the mucosa, creating what we call the major duodenal papillae. And if we were to have an accessory pancreatic duct, it will be 1 inch above, that is the minor duodenal papillae. Okay? Now the third part of the duodenum that extends from the psoas muscle to the other psoas muscle. And by default, always remember this, when we say psoas muscle, you will always find the ureter and the gonadal blood vessels running on them. Ureter, you know what a ureter is, right? Coming from the kidney, taking urine to the gallbladder. And gonadal blood vessels in females, it is the ovarian. In males, it is the testicular, they are the testicular blood vessels. So the third part of the duodenum, which is 3 inches, first part is 2 inches, second part 3 inches, third part is 4 inches. Okay, it extends from the psoas muscle to the other psoas muscle, crossing the inferior vena cava and the aorta as well, plus the gonadal blood vessels and the ureter. Now the last part of the duodenum is the shortest part, which is only 1 inch in length. And it curves to the left side to create the duodenal junction. Here it is suspended by a ligament to the right crust of the diaphragm. This is the diaphragm, this is the right crust, okay, that is the left crust. Okay? So it is called the suspensory ligament of the duodenum or the ligament of Treitz. It suspends or attaches the duodenum or the last part of the duodenum to the diaphragm. Now, if we were to open the abdomen, where is the duodenum? Duodenum is not there. It is hidden here by the peritoneum. For you to see the duodenum, you're going to have to open the peritoneum. But what else do we see? We see the coils, the rest of the coils of the small intestine. And we're talking about 20 to 22 feet or 6 to 7 meters. Upper part is the duodenum, lower part is the ileum. Right? The duodenum is 2/5, which is basically 8 feet. And the rest will be the ileum. But if you were to do a surgery on the ileum, you need ways to differentiate between the duodenum and the ileum. You're not going to form the 7 meters and trying to reach the ileum. So there are ways to differentiate between the duodenum and the ileum. Number one is that the duodenum is wider in diameter and it is thicker and redder. Why it is thicker and redder when you feel it? Because of these mucosal folds. Now these mucosal folds, we call them plica circularis, or you know them as mucosal folds. In the area of the duodenum, they are thicker, more compact, and more numerous. That's why they give the duodenum the red appearance. It's redder than the ileum. And this is the white substance I was telling you about. We ask the patient to drink this white material, it's called barium, and it will be secreted with the feces, will not be absorbed. But because of these mucosal folds here, you can see that the barium is broken into pieces. It's not a smooth outline. While as you go down towards the ileum, we have way less of these plica circularis or mucosal folds. Right? This is the area of the ileum. So that once the barium or that white matter reaches the ileum, you can see it is not broken as here. It's a smooth outline. Okay, so number one, to differentiate between duodenum and ileum is that duodenum has plica circularis or mucosal folds that are more abundant and thicker, giving the duodenum the reddish appearance. So it is thicker and redder than the ileum. Okay, so that is number one. Number two, now this is the mesentery of the small intestine. Now between the two layers of the mesentery we have the blood vessels. These are branches of the superior mesenteric artery. This is the superior mesenteric artery supplying the small intestine and other structures that we're going to see later on. So in the area of the duodenum, as you can see, the branches will make maybe 1 or 2 arches, and then we have a long terminal vessels. As you go down towards the ileum, we will have more arches or arcades, 2 or 3 or 4, and a short terminal vessels. Now the space between these arches or the arcades is called the lunates. So, in the area of the duodenum, we have lesser arcades and long terminal vessels. As we go down, we will have more arcades or arches and short terminal vessels. Okay, so this is number 2. Number 3, now in the mesentery, if you notice here, fat in the mesentery, in the area of the duodenum, is concentrated close to the roots, where it is attached to the posterior abdominal wall. It does not reach the wall of the intestine. And the way to test it, and you should do this in the lab, put your, especially if you're wearing a colored glove, put your hand behind, lift the duodenum and put your hand behind the mesentery and behind the cord, and you should be able to see your hand. Because fat does not go all the way to the wall of the intestine. While in the area of the ileum, you can see fat goes all the way towards the wall of the ileum. So if you put your hand behind it, you're not going to see your hand. So 3 differences between the duodenum and ileum. Number 1, it is redder, thicker, and wider, redder and thicker because of the presence of plica circularis or mucosal folds that are more thick and more abundant and more close to each other in the area of the duodenum. Number 2, arcades. In the area of the duodenum we have less arches or arcades with long terminal vessels. In the area of the ileum, we have more arcades and short terminal vessels. The space between arcades, or this circle here, the space between each arc is called the lunate. The third difference is that fat in the mesentery, in the area of the duodenum, it does not reach the intestinal wall. In the area of the ileum, it reaches the intestinal wall. The way to test it, you put your hand behind the mesentery. If you can see your hand, that is the duodenum. Now, additionally, in the ileum, we find these structures. On the anti-mesenteric border, meaning the border that is opposite to that where the mesentery is attached. This is the mesenteric border. This is the anti-mesenteric border. You find aggregates of lymphoid tissue. We call them Perry's patches. Perry's patches are only present or more abundant in the area of the ileum, but this is from the inside. Perry's patches are part of the lymphoid system. Function of the lymphoid system, it is mostly related to your immunity and immune system. Now we have to remember I said for the whole GI system, with few exceptions, you're going to have an outer longitudinal layer of muscles that is complete and inner circular. This is mostly for the small intestine. With the large intestine tomorrow, I'm going to tell you that the case is slightly different. Okay? But remember that the outer longitudinal layer and the circular layer, they are complete layers in case of the small intestine. Now, you have 6 to 7 meters of coils or small intestine. You cannot afford to leave them swimming freely in your abdomen. Otherwise, they might get wrapped around each other and you will have, they strangulate each other. So the way is to bring them together and attach them to the posterior abdominal wall. And the way we do that is by the mesentery of the small intestine. Mesentery of the small intestine goes and wraps the whole 6 to 7 meters and bring them to the posterior abdominal wall. So this mesentery here, or it is wrapping the 7 meters and bringing them all together, attaching them to the posterior abdominal wall here. So this is the site of attachment, or it is called the root of the mesentery of the small intestine. It's at an angle with the midline about 45 degrees. The length is about 15 centimeters. So the line of attachment of the mesentery of the small intestine, here it is 6 meters, here it is 15 centimeters. So it brings all of them together and attaches them to the posterior abdominal wall. This is called the root of the mesentery. So as I said, here it is 6 to 7 meters, here it's 15 centimeters. The depth between the root and the intestinal border is about 20 centimeters. Now this line of attachment of the mesentery of the small intestine to the posterior abdominal wall, it crosses these structures. So it crosses the pancreas, crosses the third part of the duodenum, aorta, and the inferior vena cava and the psoas muscle. So this is the line of attachment of the mesentery of the small intestine to the posterior abdominal wall. Okay, and remember, by default I said, whenever we mention the psoas muscle, we need to remember that always we will have the ureter and the gonadal blood vessels, whether testicular or ovarian, running on the psoas muscle. So the root of the mesentery, going from left to right, at a 45-degree angle with the midline, crosses these structures on the posterior abdominal wall. Pancreas, head of pancreas, third part of the duodenum, inferior vena cava and the aorta and the psoas muscle with the ureter and gonadal blood vessels. During embryonic life, there was a duct between the GI or the developing gut and the yolk sac. Now, it appears during the 4th week and it should disappear by the 7th week. But in 2% of us, if we have 100 students here, 2 of them will have remnant of this vitello-intestinal duct. This remnant of vitello-intestinal duct, we call that the Meckel's diverticulum. Now, Meckel's diverticulum, if present, it will be present in 2% of people. And it is 2 feet away from ileocecal junction. Yani this is the ileum, that is the cecum. It is 2 feet away from the ileocecal junction on the anti-mesenteric border, on the outer border of the intestine. Now, appendix is on the right side. And if you have Meckel's diverticulum, it might have the same signs and symptoms of appendicitis if it gets inflamed. But it's going to be on the left side. Okay, so Meckel's diverticulum, if present, it will be present in 2% of individuals. It is 2 feet away from the ileocecal junction on the anti-mesenteric border. And it is 2 times as common in males than in females. And sometimes we have 2 types of ectopic tissue. Do you know what do we mean by ectopic tissue? Yeah, the tissue that is present in somewhere else other than its normal place. So within that Meckel's diverticulum, you might have gastric or pancreatic tissue. When you have gastric and pancreatic tissue, it means it is secreting gastric and pancreatic enzymes and juices. So these Meckel's diverticuli are prone to ulceration, perforation, and bleeding. Sometimes, the muscular layer of these diverticuli or Meckel's diverticulum, they become weak, creating what we call the diverticulum. If it becomes inflamed, that is called diverticulitis, I-T-I-S, in meaning inflammation. Or otherwise, if it is just bulging in the wall, it's called diverticulosis. So, 2% of people with Meckel's diverticulum, well, they will present with complications like diverticulosis, diverticulitis, or because of the ectopic tissue that we might find in them, with a gastric or pancreatic,